All right, it is Dermatology Day. It is week 8, and it's the spring of 2022. And today we're going to talk about melasma and LSC, Lichen Simplex Chronicus. My voice is doing better today, but I apologize in advance if it cracks up, or I guess it sounds more like a radio voice. It's a little bit deeper, so it probably sounds good recorded, but this is not my normal voice. Anyway, melasma. What in the heck is melasma? Raise your hand if you've heard of melasma. Blink your eyes if you've heard of melasma. I don't see any eyes blinking. That's because I can't see anything except my kitchen table from here. But you probably haven't heard of melasma. So it's commonly called the mask of pregnancy because it really kicks in when people become pregnant. It's also known as chloasma or chlasma faciae. And it's a very common, I don't know about very common, but it happens. It's a hyperpigmentation disorder of the face where you get these brown blotches on your face, and it especially kicks up during pregnancy, and it likes people of color, especially Hispanics. It doesn't usually affect Caucasians as much, as we will see. And it loves the face, especially the malar eminences, which is an AK for the cheeks, the forehead, the upper lip, and the chin. And here's an example of a slight case of it, and you can see what it looks like. So it pops up a bunch of little macules. Remember what macules are? Flat, usually brown lesions that are less than 1 centimeter in size, or patches, or both. Patches are flat lesions that are greater than 1 centimeter in size. And the colors can vary, but most of the time it's a black or brownish color. The lesions cannot be raised. They cannot be crusty or ulcerated. That's something else, if that's what you have. And no nodules can be present. And what causes this? Well, we don't know what exactly causes it, but we know if you do histological sampling, we know what it looks like. So if you take a sample of this brown area, what does it look like under the microscope? There'd just be a whole bunch of melanocytes in the lesion, too many. So that's similar to lentigo, was the same sort of deal, too many melanocytes. And we know that melanocytes, they inject newborn skin cells. Remember, skin cells are called keratinocytes. So they inject the newborn skin cells with melanin, which gives you your skin color. And the more that are injected, and the more melanin your skin cells have, the darker in color you have. So many times we have these melanocytes double injected because there's so many melanocytes around. Okay? And these melanocytes are normal. They're not mutated. They're not dysplastic, or they're not cancerous looking. They're normal. There's just too many of them. And there's no abnormality with the precursors to melanocytes or melanoblasts. So those are normal. There's too many of them as well because those turn into the melanocytes, but they're not mutated is the point. So it's not cancerous. And then the other characteristic of these, as if that's not bad enough, they tend to be overactive. So they're considered to be hyperactive, just like the melanocytes of freckles. Remember, freckles are overactive melanocytes, which are stimulated by the UV radiation of the sun. There's not too many of them in Aphilodes, or AKA for freckles. Okay, so double mechanism. There's too many of them, too many melanocytes, and there's a hyperactive, and that's what causes this. This is not an inflammatory disorder or an infectious disorder or an autoimmune. There's no inflammation associated with infection or an autoimmune attack of the infection. So here's another person who's pregnant and got these blotches here. And you can see probably a couple of Aphilodes mixed in here with this person. But yeah, that's melasma. And you, now that you've seen this, you go, oh yeah, I've seen this. Maybe your grandma has it, or your mom had it, or you've seen this before. And another one. This is looks like a person of color, probably looks like Hispanic, but you can see over the lips, and you can see it here. And yeah, and so it's not dangerous. It doesn't turn into cancer. But of course, psychosocial issues. I mean, if you're a young person and it's bikini season, you're going to the beach, maybe not the coolest thing to have, and it's very difficult to treat. So there are it can cause psychosocial issues and depression and things like that. But in and of itself, it's not going to shorten your life or do anything like that. And yeah, they call it the mask of pregnancy because it loves to show up during pregnancy. And after pregnancy, it may disappear. It may be lingering around, but it should be lighter after pregnancy. People who take estrogen and progesterone replacement hormones, they can have the same thing. So it's related to, I forgot to put in there, it's related to the estrogen and the hormones of pregnancy. The progesterone seems to be what stimulates those melanocytes to overproduce and become hyperactive. Who's at risk? We already said Hispanics are particularly at risk, but African Americans and Asians, people of color, in other words, they're at risk. Caucasians don't seem to be affected by this one. There's another person who's got it pretty severely. Risk factors. Strongest risk factor is probably genetics. Ask mom and dad, grandparents, did they get these blotches on their face when they got pregnant? Maybe they still have them. My wife still has these a little bit. Not, they're pretty faint on her, but two of my daughters have them as well. So genetics, and I took all the gene stuff out. That's just getting too deep for this class. But there is a gene associated with these. Also, a history of UV radiation. I know I sound like a broken record there, but letting your kids get burned is just a bad idea. 20, 30, 40 years later, they could have melanoma or they could have all sorts of skin-related lesions. So keep the sunblock on those young teenagers of yours and young kids of yours. Being a female, this is a female disease as well. 90% of those affected are female, so this is a huge female target disease. Yeah, we already said people who are menopausal and are taking estrogen, progesterone therapy are at risk. People with thyroid disorders, they've been seen in both hyper and hypothyroidism. Some people, cosmetics, cheap cosmetics, or they just almost seem to have an allergy to cosmetics. They can have a breakout of melasma from certain types of cosmetics. And then anti-seizure medication. The reason I throw that in there is because a lot of your patients are going to be on something called Neurontin. Your sciatica patients, that is. Chronic sciatica, Neurontin and Lyrica are the old standbys. This is called gabapentin as well, and that does have increased the risk for developing melasma. Right, here's another patient. Looks like she's had maybe some kind of lesion removed right there. All right, so what can imitate melasma? Well, lentigo, I mean, it's almost the same pathophysiology, so it can look just like lentigo. Although lentigo is a little bit, usually not quite as large as melasma can get, but when melasma is first starting out, it can look like lentiginous. SK, which we'll talk about next week, I believe, seborrheic keratosis, hyperthyroidism-related conditions, has a certain type of rash, HIV infection, and then the contact dermatitis is, hopefully we can get to that one next week as well. But they all have unique kind of rashes, and they can look like this. Very tough to treat. Treatment really doesn't work that great. The best way to go is a combination treatment or even a triple type therapy is the kind of the gold standard right now, where you use a retinoic acid type of medication like tretinoid, use creams, corticosteroid creams, and then you can use a lightening agent as well, the hydro quinone. That's the classic kind of 1, 2, 3 punch for it right now. There's some other treatments which are a little more sketchy: chemical peels, PUVA therapy, laser therapy. They're kind of hit and miss to my understanding. And the best way to prevent them is to cover up, prevent UV radiation damage on your teens and right now as well. So sunblock that has UVA and UVB. Blocking abilities is what you need for this. I should say don't get pregnant because that'll increase the chances, but what are you going to do? This is not, again, it's not a life-threatening disease, or it doesn't have any sequelae other than the cosmetic appearance. There's another one here. Picture's a little bit red, but see how it's much broader than lentigo lesions are more localized. We looked at lentigo already. Person of color. All right, so that's the end of melasma. Another fairly common one, not as common as melasma, is called LSC, Lichen Simplex Chronicus, and it is the scratching disease. In fact, that's what manifests or perpetuates this disease is scratching it, either consciously or subconsciously at night. Neurodermatitis is a strong AKA. It's got a lot of AKAs, like lichenified eczema, because the lesions they're eczematous looking, but they like to lichenify. So lichenification is common here. Circumscribed neurodermatitis, lichen simplex. You get the deal, and it's pronounced Lichen Simplex Chronic, like igloo icus. It is a disease that causes a type of lesion called an eczema, and we've talked about eczema is not a disease in and of itself. When we're talking about psoriasis is another disease that presents with these types of lesions, but we're going to get into eczema here in a second. It is fairly common. The prevalence is about 12% of the population will have a bout of this, and it may disappear and never come back, or it may come back again. I've had a bout of this, not horribly, but after some flea bites. I'm allergic to fleas, and my wife noticed I was scratching it at night with my heel and perpetuating this rash, so I had to go to sleep with shoes on, and that took care of that problem. But yeah, it started by some type of insect bite, or it's a scratchy rash occurs and you scratch it and it just perpetuates. This is typically localized to one area of the body, so it's not going to be a exanthem type lesion or rash type lesion, because you have to be able to itch it, and it has to be in an area where you can actually get to itch. And it's perpetuated by patient scrub or itching and rubbing. And yeah, so the scratching starts a local eczema. And again, it's not widespread. You can see it here on the patient's back of the hand, dorsum of the hand here. And now we'll fall in a little rabbit hole. Let's talk about this eczema, because I've said it, but I haven't officially said it. So an eczema is not a disease. There is no eczema. An eczema is a type of skin lesion that you get. And there are many different diseases that can cause eczema. Collectively, those diseases are called eczematous dermatoses. So LSC is one of the eczematous dermatoses. Psoriasis is one of the eczematous dermatoses. Why are they eczematous dermatoses? Because the skin lesion type that they produce is an eczema. Right? So here's a whole list of these are the eczematous dermatoses that all present with eczemas. So there's our LSC, Lichen Simplex Chronicus. We talked about that. Psoriasis, I didn't add it on here because when it first pops up, it looks like an eczema, but we said psoriatic lesions, they get that silver white scale on the top later on. So they shouldn't be included here, but when they first pop up, they are. So I guess we will not officially include them as an eczematous dermatosis because later on you can tell them apart. The contact dermatitises, the allergic, there's two types, allergic and irritant. They present as eczema. Stasis dermatitis, infections, ichthyosis vulgaris. This starts out. Later on, you can tell what this one is too. Seborrheic dermatitis, food allergies, discoid eczema. Those are all types. I would definitely know the atopic, the LSC, contact dermatitis, the stasis dermatitis, food allergies for testing purposes. So how does the lesion become an eczematous dermatosis or an eczema? There's three real big characteristics. It's going to be itchy. It's going to be red in color. And it's, really, it's two big ones. Almost all of them are itchy and they're red looking. And then they can become excoriated from the scratching. That's where they develop kind of a crusty, bleeding scab type thing. So that's excoriated there. Okay. And then they can become lichenified, and some of them, like LSC, becomes lichenified very early. So that makes an eczema. Excoriation means that there's a hole in the skin. The epidermis has been removed, and the dermis may be removed as well. If just the epidermis is removed, then it'll heal. If the dermis has been removed, you're going to have a scar from that. And it can be caused by injury, fall on the pavement, scratching, anything that rips off the skin. An infection eats off the skin, so that could do it as well. And the infection and the autoimmune attack, the inflammation that occurs, can eat a hole in the skin as well. And then, it can form a crust from the bleeding and the oozing. And here's some eczematous type lesions. So this is definitely crusty. This is seborrheic dermatitis. This is discoid eczema, which looks as an eczema condition where you get these kind of circles. This is a perfect eczematous lesion. It's lichenified, right? It kind of looks like tree bark. The skin is accentuated. It's red. It's most certainly itchy. All right. Here's a contact dermatitis from wearing latex gloves. It's red, and we know it's itchy. You'd have to get that from the history, though. And it's excoriated. It's got a little bit of little scabs healing here. Looks like it's in the healing phase, though. Here's another one that looks like it's in the fresh phase and it's been itched. Looks like it's had some steroid cream rubbed on it, but you can see the fresh lesions here, and it's healed here with a crust, and this is classic eczema. It's an old insect bite, and it turned eczematous. And 6 months later was still there. The patient kept itching it, and it then was diagnosed as LSC. All right. What are the risk factors for developing LSC? Dry skin, a history of atopy. Do you guys know what atopy is? I assume you know that from pathology days, Cooperstein. Atopy is, or maybe public health. Atopy means you're allergic to everything. You get sinusitis in the fall and in the spring. You get allergies. You probably have a touch of asthma. You're allergic to peanuts or shellfish or cat fur. If you have this, if you're sensitive to all this stuff, you're atopic. You have atopy. Okay, so that increases the risk for development. Systemic diseases like amyloidosis, super rare, but that can do it as well. Some people just have really hypersensitive skin, and it's really easy for them to, if they scratch it, they scratch the epidermis right off it. Psychological conditions the skin is normal, but there's a great satisfaction some people get from itching. It feels really good, and they like that feeling. It's thought they get an endorphin release from that, so they like to scratch it. So people with anxiety, OCD, obsessive compulsive disorder people are much more commonly develop LSC than the normal population do. Where does it occur? Favorite targets are the distal anterolateral legs, or it could be anteromedial legs, which was where mine was, but the distal legs where you can itch with your heel at night subconsciously, the scrotum, vulva, perineum, wrist, ankles, eyelids, back and side of the neck. So these are places that you will see. And here's somebody who's got it on their eyes and around their eyes from itching and rubbing during allergy season, and they just won't stop itching. The epidemiology, so very uncommon in childhood. This is not a childhood disease. It's more likely atopic dermatitis, which I don't think we'll have time to get to. So make sure you watch my YouTube video on that before boards. A peak incidence is 40 years of age. So women, so it's a kind of a middle-aged disease. Again, women are much more affected than men. This one has no racial preference. All races are affected the same. And again, we said the prevalence is about 12% of the population. And pathophysiology with this thing, you get in a vicious cycle of itch. And if we leave out the dopamine factor, it's still there. So you get an itch, you scratch it, maybe that feels good, but the scratching will cause release of histamine and more itching, more damage to the skin, more inflammation. You have to itch it again to feel better, and you get in that vicious cycle of scratch, histamine release, and endorphin release. You need to scratch it again to get some relief, etc. And yeah, lichenification can be a factor in this as well. And yep, here's very similar to my case. So if winter flea bite started, mine was on the inner side, the medial side of the ankle. This one's on the outer side. Mine look very similar to this, not quite as bad as this. You could see the lichenification. Look at how the skin is magnified here. It's red, it's lichenified. There's some crust on it from being scratched. Looks like it's healing up pretty good. That's classic Lichen Simplex Chronicus. Some people seem to become wired for itch and as well after chronically scratching it and going through that cycle over and over. Some studies have shown an increased density in the number of itch fibers. Those are unmyelinated C fibers, which are the ones that also carry pain. And so if you have a better ability to sense itch, well, then it's going to itch and you're going to scratch it. When most people, it wouldn't be itchy anymore. You're going to be itchy because you've built up all these extra C fibers. And so, yeah, and some studies have shown that these people who get LSC regularly, they have increased number of mastocytes, which of course are the ones that release histamine, and histamine is going to make you itch. So some people, just like some people can become wired for pain, some people can become wired for itch. I had a client 2 weekends ago who emailed me back. He had microdiscectomy, and his problem, this is rare. I've only seen this a few times, and I've been doing these consultations since 2003. I've only seen this a couple times. His problem was not horrible burning electric sciatic pain. His problem was itch. And he went ahead and had the discectomy, and he said the itch went away, but now he's got some burning pain. And I didn't recommend the surgery to him. I didn't think he was bad enough, but people pay me a lot of money sometimes, and they don't take my advice, and he probably should have, because now he's got, instead of itch, he's got sciatic pain. Anyway, so that makes sense, right? Because the pain and itch are carried over the same fibers. What's the, if you develop LSC, what's the story? What's the natural history or the life outcome of this disease? It tends to be reoccurrent. So like for myself, if I get bit by fleas, I will do everything in my power not to scratch them one time, because I know I can easily get in that cycle again. So it can be tends to be reoccurrent disease. And early on, the appearance of the lesions, it's typically just an eczema without lichenification. Later on, with chronicity, the lichenification occurs, and it may permanently damage the skin in some cases. Mine it didn't, though. Okay, here's another one. So this is another patient who is rubbing the ankle area, just the dorsum of the foot. It's got a LSC lesion. Okay, here's one chiropractic patient, perhaps, laying on the table. Saw him itching in the waiting room, and you looked here, and there's an eczematous lesion. And early psoriasis can look like this as well. I've seen students who've looked exactly like this and turned out to be psoriasis early on, before the silvery scales develop. But that's LSC. We already said early psoriasis can also present with these lesions. But they become more silvery, flaked, and raised later on. We already talked about that, but here's psoriatic lesions. Some pretty wicked calluses there for this guy, too. But yeah, what's the treatment? You got to stop itching. I had to put shoes on at night to stop myself from subconsciously itching. So put mittens on if you're scratching it with your hands. Do what you have to do, but you have to stop itching it. And use cortisone cream. Will stop the itching. Without that, I don't know if I could have done this. It's very good at stopping inflammation and itch. Don't want to stay on it forever, though, because it has some negative consequences. Clobetasol is a classic one that's used. There's a bunch of them. You can also put painkillers. You can use a lidocaine patch, because pain and itch go down the same nerves. Any of the topical pain medications will work as well. And then antibiotics might be needed if things get infected. All right, thanks for listening. Here is our bird for the day. I don't think I gave you this one yet, but this is called a bufflehead duck, shot at Moss Landing over in the winter. These are more winter birds. They're up in Canada during breeding season right now, but during non-breeding season, you'll see these at reservoirs, and they're really pretty duck. So that's called a bufflehead. All right, see y'all later.